Welcome, everyone. My name is Ann Clement. I'm Global Marketing and Communications Director for Oncology Solutions at GE Healthcare. I want to thank you for joining us today for our scientific session, Perspectives in Imaging, a webinar on trends in radiation oncology. Today, we are inviting you to join our key opinion leaders to discuss trends we're seeing in radiotherapy and who together can help improve innovation and the overall patient experience. But before anything, I wanted to take a few minutes to review a few housekeeping tips and some helpful hints. So first of all, at the bottom of your screen, there are multiple application widgets that you can use. All of these widgets are resizable and movable. You can expand your slide area, or you can maximize it to full screen by clicking the arrows in the top right corner. This is very helpful when you want to look at the speakers, or if you want to look at the slides, depending on what is the greatest focus. Under the resource list, you may find some additional helpful materials as well. And at any point during the webcast, you can enter your questions in the Q&A, and at the end of the talk, we'll be having a live Q&A session where our panel of experts are going to help to provide answers to your questions. We're certainly going to do everything to get to all of your questions during the session, but if for some odd reason we cannot get to you, we will capture these and we will follow up in the email, or we'll make them available in the replay link as well. Lastly, an on-demand version of the podcast is going to be made available to you in a very short period of time, so you can check back if you want to watch the replay. You'll also receive an email with an accessible link. You can feel free to share that with your peers and any colleagues that you'd like. Now, without further ado, I want to take this moment to introduce our moderator, Andy DeLeo, who's the Chief Marketing Officer for Women's Health and X-Ray, and is also a very important oncology expert and influencer. With that said, Andy, over to you.
Thank you, Anne. Good morning, good afternoon, good evening, everyone. I want to welcome you to today's webinar, our Trends in Radiation Oncology. I'm super excited about today's webinar, especially because we've got representation from 4 of some of the most brilliant minds in radiation oncology spanning the globe. So with that, what I'd like to do is just give a moment for each of our guests and our KOLs to introduce themselves. So we'll begin in the US first. Dr. Haas?
Yep, Andy, thank you for inviting me, and everyone, thank you for attending. So my name is Dr. John Haas. I am the chairman of radiation oncology at the Perlmutter Cancer Center at NYU Long Island School of Medicine.
Hi, hi everyone. Again, thank you, G, for inviting me here. I'm Dr. Srinivas Chilakuri. I'm a senior consultant, radiation oncologist at Apollo Proton Cancer Center in Chennai in India.
Okay. Hello, everyone. This is Dr. Sun Bai from West China Hospital. It's my great honor to join this webinar by invitation of GE. Today, my team and I will be joining the discussion together. Thanks. Okay.
Hi, thank you very much for inviting me here. My name is JJ Wyatt. I'm a radiotherapy physicist, associate lecturer at Newcastle University and Newcastle Hospitals in the UK.
So thank you for those introductions, everyone. One of the first things that I'd like to start and just ask our team is, we know that there's a lot of innovation, especially in radiation oncology. So over the course of the last 4 or 5 years, how do you see that radiation oncology has evolved? So maybe what we'll do is we'll start in Dr. Chilakuri, if you could maybe start answering.
Yeah. So last 4 or 5 years, we have seen consolidation of the high precision radiation therapy techniques, which we have been doing for last 20 years now, almost. We have seen radiation oncology becoming more patient-centric in the form of, with the advent of, hypofractionation schedules, moderate and extreme hypofractionation, where these are extremely convenient patient schedules, treatment schedules, which can be finished very quickly. We've also seen the radiation oncology indications expanding in situations which were usually routinely not advised as a standard modality. We've also seen a lot of data being used in radiation oncology to good use in various ways to basically automate many of the steps in radiation oncology, which and I think it triggered adaptive wave, a wave of adaptive radiation therapy, both online and offline. This automation has triggered the use of adaptive radiation therapy techniques. We've also seen emergence of image guidance in a big way. Of course, we had cone beam CTs and KV X-rays and others even before, but the resolution has significantly gotten better. We've started using MRI on board in the clinic routinely, and that, again, a significant change in radiation oncology. Particle therapy, also, we have seen that it has consolidated in a bigger way. We've seen a flurry of new proton therapy centers, a lot of new clinical trials for evaluating particle therapy, and a lot of emphasis on precision radiation therapy, not in terms of physical precision, but biological precision in terms of patient selection, optimization of dose, advent of genomics, and many other things into radiation oncology.
Thank you. Dr. Haas, from your perspective, how would you, sort of think about the way that radiation oncology has changed over the last 4 or 5 years?
Yeah, it's tough to follow Dr. Chilukuri because he really touched on all the high points, and I agree entirely with every single thing he said, but it really is kind of the dissemination of precision and technology. So, we were one of the earlier users of SBRT, close to 20 years ago, and now that's become standard of care as opposed to being an outlier. So it's exactly about patient centricity, optimizing treatment, making it more comfortable for treatment, making the time better, expanding indications. So Dr. Chilukuri was alluding to expansion of indications. So in the past, patients had metastatic disease. Those patients were never really considered candidates for radiation, but there's a ton of really good high-quality phase 3 data. The SABRE Comet trial, for example, where patients that have low-volume metastatic disease that we would never touch in the past except for palliation, we now treat those patients for cure. You can a patient that has low-volume prostate cancer that has 2 or 3 metastases, we'll treat those patients with the highest level of data, showing that we can cure those patients. Integrating genomics is a great comment. So we send many of our patients for the genomics of their particular cancer. If a patient has prostate cancer, which is my area of expertise, and they have classic intermediate risk cancer, which is a Gleason 7, but we sent them for genomic studies, and they're low risk, those patients be safely watched, or the converse is true. Similarly, looking for breast cancer, with oncotype scores for breast cancer. Advancing precision in the clinic itself, integrating imaging with our CT simulators, MR simulators, functional imaging, PET-CT integration with our planning process. So really, it's really kind of the technology that is exploding right now for the benefit of the patient.
Thank you, Dr. Haas. Dr. Bai, could you share with us some of the trends that you're seeing in China?
Okay. Over the last 5 years, many new technologies have emerged in the area of radiation oncology, such as FLASH, proton and heavy ion therapy, cardiac radioablation, and AI. For FLASH technology, which uses ultra-high dose rate to kill cancer, could bring flash effect, which means that the radio sensitivity of normal tissue is significantly reduced. But tumor tissues are still sensitive to radiation. By using FLASH, we could reduce fractions of radiotherapy, increase tumor cure rate, reduce toxic and side effects. And for proton and heavy ion therapy technologies, using these technologies, normal tissues can be better protected while efficiently treating tumors. And for cardiac radioablation, which can cure patients with ventricular arrhythmias failures of drugs or catheter ablation. Conventional VT ablation can be limited by incomplete or difficult target accessibility, with subsequent arrhythmias, persistence, or recurrence after ablation. Radioablation has the potential to overcome these limitations. And finally, for AI, artificial intelligence. In radiotherapy, AI can help with prediction, out-plan designing, out-tumor target and organs at-risk segmentation, imaging quality improving, and so on. By using AI, the time of the whole process of radiotherapy is shortened, and patients will have received more individualized treatment. There are also many other new technologies, but I think that powerful technologies are more critical in the new technology and will play an important role in the development of radiotherapy technology. Thank you.
Thank you. So, Jonathan, we've heard, from Dr. Chilukuri, Dr. Bai, Dr. Haas, in regards to a lot of the trends. I'm sure that, you're experiencing very similar trends as well from your perspective, but I'd also like to know, from a physics perspective, what are some of the additional trends that you are seeing that's facilitating and enabling some of this adaptation with the new trends?
Yeah, thanks, you. I totally agree with what has been said already. I think I guess one point that maybe has been less highlighted has been the increase in efficiencies within treatment planning and contouring, which, particularly what is, now increasingly becoming sort of the role of automation in treatment planning, role of automation in contouring, both of which are key, essential building blocks to enable a sort of adaptive radiotherapy process where you are adapting treatments, whether online or offline. But the key driver for that is the efficiency that you can get when you automate planning and contouring processes. And so I think that is something which we're really, is really becoming a strong trend. And the other one really to pick up on, I think, was again mentioned previously by Dr. Haas, but in particular, sort of pre-treatment imaging and the use of not just CT, but the use of MR, the use of PET, to provide you with a much bigger and richer picture of the tumor, but also a more precise delineation and a more efficient delineation because of the improved image quality and also the additional functional and metabolic information that you get. And I think that, again, is something that has really sort of increased over the last few years and is a real trend for the future, where we will be moving away from sort of delivering kind of homogeneous doses over the whole of the target, and rather identifying using functional imaging areas of particular subvolumes of particular activity and giving them, boosting higher doses to those regions.
Thank you. So one of the trends that we're also, reading about, hearing about, and starting to see clinically is the use of theranostics. So maybe we'll begin with Dr. Haas. Dr. Haas, from your perspective, when you think of, the emergence of theranostics, whether it's independent or in conjunction with, the standard external beam radiation therapy, sort of what's your view on theranostics and the role that it's going to play in the future?
Yeah, I think it's going to be a major part of what we do. So, for example, once I leave this webinar, I'm seeing a patient later today that had a prostatectomy, and his post-operative PSA was 4.7, which is way, way too high. So we had a conventional Axeman PET CT scan, which showed a questionable lymph node in the pelvis, but we're going to send him for a PSMA scan. So, if you have a prostate-specific membrane antigen study, we find disease outside of the pelvis, depending on what we find, it's really going to impact designing radiation fields. So we're just starting to get into it. But if you have targets that you can attach therapeutic agents to, if you have targets that you can attach imaging ligands to, it's going to be a whole new frontier. We haven't, or I haven't, at least started using it clinically as far as treatment yet, but we are definitely using it in diagnostics. So I think it's going to explode over the next couple of years.
And Dr. Chilukuri, what about from your perspective? What are you seeing in terms of the use of theranostics in your region?
Yeah, theranostics, I think India has been kind of the forefront of its use. We've been using PSMA PET scans now for the last 10 years or so as, it's not as standard, I would say, but in multiple settings. So similarly, we have been using theranostics for hepatocellular cancers, for neuroendocrine tumors, for prostate cancers, and many, many other cancers. And I think it's an extremely attractive proposition because it is essentially, extremely targeted therapy with radiation therapy. So it's combining the best of chemotherapy, systemic therapy, and radiation therapy. And you mentioned regarding the combined, treatments of external beam as well as radioligand therapy. I think those are also extremely attractive because the external beam radiotherapy is taking care of the gross disease. You could use that in prostatic cancers where there are multiple scans you would do to select patients who would be suitable for these particular treatments. We are using routinely lutetium therapy as part of patients of prostate cancer. And recently the trial, it's called Vision trial, which was presented at ASCO this year, which actually showed level 1 evidence that lutetium really works in metastatic setting. And similarly, I think in many other cancers, there is a huge role coming up. Who's going to do it? That is always a question mark. In India, radiation oncologists per se do not do theranostics, therapeutic, which is actually theranostics. But the nuclear medicine physicians who use unsealed nucleotides, they are the ones who actually use to treat these patients. Nevertheless, I think different radioligands are now available, beta emitters, alpha emitters, extremely, again, innovative field. And I think this field is also going to explode in a big way in the next few years.
Thank you. Dr. Bai, in China, what is the experience or sort of the trend when it comes to the use of theranostics?
So theranostics and its combination with external radiotherapy will help doctors have a more comprehensive understanding of the patient's condition and to choose suitable treatment methods, which could provide patients with individualized therapy and reduce the burden of patients and hope to achieve better curative effects.
Thank you. And Jonathan, can you share with us, from your perspective, how you're seeing theranostics being used clinically?
Yes, so I guess similar to India, it's a split thing where the radiotherapy, the external beam radiotherapy department sits in one part, and the sort of the nuclear medicine department would handle the radionuclide therapies. But certainly they are growing. There's a number of trials going on investigating this area, and I think it is one of those areas where there has a great potential. I think it still feels at an early phase. Certainly in the UK, I don't think would not be widespread routine, but it has a great potential to change the way we treat some of our patients.
Thank you. So I'm going to transition sort of themes and topics. We started with trends. And if I just go back to the opening, both, Dr. Chilukuri, Dr. Haas, Dr. Bai, Jonathan, you all mentioned just a lot of different trends. And I can only imagine that as those trends come on board, trying to sort of grab your arms and wrap them around all of that information becomes very difficult and very complex. So maybe if we start with, what are some of those challenges about, just wrapping your arms around that information? Maybe we'll start with that. So Jonathan, do you want to maybe start with that question?
Yeah, I mean, I think you end up with a situation where you have a lot of different data sources, a lot of different data streams feeding into your decision making, a lot of them coming in different systems, different, that are not compatible with each other. And I think that can be a real challenge to work out how to utilize them best within the radiotherapy setting, so that you're utilizing. So I think a key thing is really thinking about is interoperability, and is working hard with the vendors and the manufacturers of these different tools, and to try and make sure that those data streams can really line up, so that the critical information can be sort of seamlessly tied together, and it's working out what platform is the best platform to do that in is also, I think, key to. And again, it feels like you're at this. Yeah, that one of the trends in technology generally is that actually, as the technologies become more mature, a lot of the complexity starts getting buried down, and I think that's where things like artificial intelligence algorithms have a real role to play, because they can provide ways of aggregating lots of different channels of data information into more simple presentations that then rather than relying on the clinicians to have to try and integrate lots and lots of different things all together. But that certainly feels like it's going to be a major challenge, and one of the potential areas of growth in the future.
Thank you. And Dr. Haas, especially because, you're sort of in the heart of New York City, you see patients coming from, all over. Can you share with us some of your, experiences when it comes to the challenge of just, following all of that information, wrapping your arms around that information, and how you go about solving that?
Yeah, well, the easiest way, indications, I think, or new indications, I find the easiest. And the easiest way I find, just as a physician, is with the highest level data. So getting back to the example I used earlier on with low volume metastatic disease. So fortunately for me, there were researchers throughout the world that looked at the indications for expanding local radiation to the metastatic setting. So once you have peer-reviewed data, and the best is when you have phase 3 data, adopting that new indication or technology is easy. The more difficult issue is when you have competing technologies or competing new AI platforms, imaging, and they're all expensive. And this, I'm fortunate to work with Dr. Matt Witten, who, in addition to probably being the only person that compete with you on a fashion level, Andy is a person who I trust implicitly as far as adopting new technology. We have a running joke in my department that we're Captain Kirk and Mr. Spock. I'll do anything. He reins me in to make sure that it's safe. So if Matt Witten comes to me and says, this platform, this contouring station, we're looking to update our whole planning system shortly with a complete AI system. If Matt Witten signs off on it, I know it's safe, and I'll obviously look at it. So I have the advantage of, and it gets back to the team approach, and I'm sure all the eminent people on this webcast with us have teams that they trust. I trust my team. So I have a chief of physics that I trust. I have a technical staff that I trust. If they say this technology is worth looking at, then we'll drill deeper and go to the vendor and get an in-service on it. So indications are easy for me as far as peer-reviewed data. New technology, to answer your question, is a little bit more difficult, but I have a team that helps me, and then we'll go to the meetings such as ASTRO, AAPM, or have the vendors come to us.
Thank you. And Dr. Chilukuri, how do you, address this same challenge?
So the challenges are, I think, in a different context in India. I think India itself is a big country, and there are multiple Indias within India. There are regions or geographies and hospitals where basic access facilities are not universally present. Most of the data is not electronic. I think that is the biggest challenge, where, if the patient is coming from that part of the country, you will have to skim through hundreds and thousands of pages of documents and reports, some useful, some really useless. And you have to make sure that you're not missing anything, and patient safety issues, all those things come into play. And there are others who have luxury of using electronic medical records, EHR, and sophisticated ones. But again, there are issues with integration. I mean, you'll have to open 3 different windows to get the complete information about a patient, and so that you're not missing anything and the patient's information is not falling in between the cracks. So I think that is the biggest challenge for us in our setting, that making medical records electronic is the key issue, and I know that the government is also doing on its behalf. It's doing what all it everything it can to starting a new digital health mission, which the government has started. But there are many hospitals which need to come to that platform, and of course system integration issues. I think these are the key challenges which we face on a day-to-day basis.
So, Dr. Chilukuri, I'm just going to kind of expand slightly on your answer and interject another question. When we think of patient care, oftentimes at the center of it, whether it's a virtual or in-person tumor board, is sort of the point in which all of the treating physicians come together and really discuss those cases. So as we see different trends such as theranostics, the use of genomics, you've got the typical clinical data as well that comes from radiology, pathology. You've got your counterparts in medical oncology and surgical oncology. How do you deal with just that flood of information, especially to make sure that it's all there and presented and discussed during the tumor board?
As I said, we have the luxury of having a world-class EMR, which is homegrown, which is tailor-made for us. And we have a network of 14 different hospitals across the country. So we, across the hospitals, we have network of interconnected systems, which enables this as good as any other hospital across the world. So the information flows freely. There are packs, of course, but there are 3 different systems or 3 different platforms. The radiation oncology works on a separate island a little bit. The PACS work on a different island, and the EMR works on a different island. So all 3, the challenge is to have a seamless connection between these 3. That is a work in progress as far as our hospital is concerned. But I think we have several workarounds which have been devised in our setting to make sure that there is no information gap which exists between, say, between 2 different personnel who are looking after the patient.
Thank you. Jonathan, from your perspective, as we talk about the interoperability and the challenges, from your perspective, especially from the physics perspective, how challenging is that workflow?
It really depends, but it can be quite challenging, depending on the setup and depending on the as people have already said, you can often end up with lots of different platforms that you're then trying to connect together and ensure that is safe and as seamless as possible. I think radiotherapy is a complex workflow. Compared to many other in the hospital, it's a complex workflow involving a lot of different members of staff, a lot of different software platforms doing different things at different points. And I think trying to streamline that as much as possible is really key. And I think there is growing trends for oncology or radiotherapy software packages that are seeking to encompass to keep everything under one root, in one package, to say that actually this is the one platform on which we can do everything else in. And I think that has real potential to make, to stop all the time people spend pushing, importing data, exporting data, pushing it from one platform to another to do one task and then back again. I think streamlining those things can make a big difference in the efficiency and smooth running of a department.
Thank you. So Dr. Haas, I'm going to transition topics yet again. And I'm leading this one with you just because I know your passion for hypofractionation. So if we look over the course of the last decade, we see, the adoption and the move into hypofractionation is mainstream and being accepted clinically. But with that, we also know that imaging has also played a role, both, sort of pre-treatment in the simulation. There's multimodality using MR and PET-CT and CT imaging. And now there's also onboard imaging with adaptive imaging as well. So could you, sort of talk a little bit through that trend and how you've seen the role of imaging really play a part in the adoption and move into hypofractionation?
Yeah, so it's a great question. So and you're right, hypofractionation is really where I've hung my hat for the last 16 years, or a big part of what I do. And our field is a precision-based field. To oversimplify what we do, it's marksmanship, right? If we could give a gazillion units of radiation, whatever that is, to a tumor, and 0 units of radiation to the normal surrounding anatomy, at least locally, we'll cure that problem. And it all starts with how you see the tumor, right? So back in the day, you had a fluoroset. You just looked at a respiration and looked at a fluoroscopic image of a lung tumor going up and down. Then you had CT imaging, where you could see a lung tumor. What happens if you have an atelectatic lung collapse? You're not going to treat all that. So then integration of MR imaging. So delineating interfaces between prostate and rectum, prostate and bladder. So further focusing, but getting back to precision now, maybe integrating functional imaging. Right, so doing, integrating, with an MR with contrast, doing what's called a simultaneous integrated boost. So in my wheelhouse, prostate cancer, creating the whole prostate with a certain dose, but we can see where the PIRADS 5 lesion is at the left base and giving extra dose there. Integrating PET-CT, further focusing imaging to see where's the metabolically active tumor within the larger organ. So we're getting better and more precise, and precision is shrinking. So as the precision gets more accurate, you can escalate the dose within a tumor, de-escalate the dose outside of the tumor, protect normal anatomy better. So we're focusing and shrinking and getting more precise and escalating dose. So that's where the trend has been over my career, and that's where the trend continues to go, in my opinion.
Thank you. Dr. Bai, could you share with us your perspective on advanced imaging in China?
Okay, hypofraction radiotherapy deliver high dosing very few fractions, and due to high dose perfection, precise localization, delineation of tumor target, and precise treatment have become very important, which means that imaging both on broad and advanced simulation are indispensable. We saw that further development of imaging technologies during treatment is needed. cardiac radioablation, as we mentioned before, is a kind of hypofraction treatment. And because the main organ at risk of cardiac radioablation is heart, precise target area segmentation is very important. And pre-treatment imaging, including heart structure imaging and function imaging, will help doctor distinguish target area with normal tissue. Meanwhile, the imaging after treatment is of equal importance, which help with treatment evaluation. Therefore, the development of high-quality cardiac imaging technology, restoration technology, and automatic delineation technology will be of great help for cardiac radioablation. And then, during radiotherapy of thorax of abdominal tumors, respiration motion can cause tumor displacement that affects accuracy of radiotherapy, especially for SBRT. 4D CT imaging is commonly used to generate an internal target volume contour that represents the volume in which the tumor moves throughout patient respiration. For regular respiration, the use of 4D CT has the potential to decrease the presence of artifacts compared to conventional CT scan. However, patients with lung cancer often have irregular breathing, which can cause artifacts in the 4D CT scan because of improper face division or residual motion within the face. So these artifacts directly affect the target volume delineation. Therefore, if new 4D CT reconstruction technology could be developed to compensate for irregular breathing to help reduce artifacts and delineate target precisely, we will have more confidence to deliver hypofraction treatment.
Thank you. Dr. Chilukuri, I'm going to change the question just slightly. We've heard, sort of the trends and the differences as imaging has emerged. From your perspective, what are the, 2 or maybe 3 things that you really need from an imaging company in order to help you in your clinical practice?
Well, I would need better cone beam CT images. I would probably need cone beam CT images quality, which is very close to the diagnostic CT quality, wherein I can generate a synthetic CT through electronic density information. You have the full electronic density information on the synthetic CT generated through a cone beam CT, wherein I could really see the dose deposition very, very confidently. I would like to see more accurate dose calculation algorithms on, say, especially when I deal with particle therapy, proton therapy, and I need very, very accurate CT imaging, which will nullify the artifacts to the lowest degree possible, so that my Monte Carlo calculations are accurate. I always use robustness kind of cutoff of 3.5 plus minus, assuming that there would be error in the dose calculation algorithm because the CT is not extremely accurate it's accurate within a very short range of Hounsfield units. So similarly, I would expect a lot of automation. There is automation, but I would want much better automation in terms of the therapist who is not as trained as radiation oncologists to match images confidently on a daily basis, use deformation on a daily basis to generate to generate adaptive to be able to deliver adaptive plans. Apart from this, I think there is also issues of image registration. They are good, but they can be better. When we use multimodality imaging, you see CT, PET, and MRI, they are in different positions, and there are algorithms which are using multiple ways to fuse these images in different treatment positions. Nevertheless, they are not as, I mean, they're there, but they're not as good as we want it to be. So I think if I have to summarize three things, the cone beam CT needs to be better. It needs to be, the CTs need to be more accurate, CTs and MRs. We are able to now build synthetic CTs from MRI. Again, we want much better versions, but also from cone beam CT. I think that is one of the key things which I would like a company like GE to take up.
Thank you. And Jonathan, what about from your perspective? What would be the two or three top things that you would expect or want for imaging?
So I think one of them certainly would be improving CBCT image quality, and I think exactly as suggested. I think generating synthetic CTs from I think that is a key perspective generally, is actually trying to generate more image modality information from a single imaging visit. So I think what we see already with an MR-only workflow, where you can get rid of the CT entirely and generate a synthetic CT from an MR, I think being able to do that as well for like cone beam CT for other imaging modalities would have a huge benefit. I think the image quality on treatment for a conventional LINAC, a non-MR LINAC, is a real is now one of the weak points in the imaging chain. I think the second one is the second thing I want to see used, I guess, is facilitating the use of sort of more advanced functional imaging techniques to be used in radiotherapy. So that there are a number of, say, for MR, diffusion weighted MR, dynamic contrast enhanced MR, but the processing, that these imaging modalities, these more advanced images are quite sensitive to the parameters that are used, to the way the patients are set up, to the way the images are acquired, to the way the images are processed. And radiotherapy critically depends on sort of consistency, repeatability, robustness. And so I think we'd really want to see, can imaging companies work on diffusion weighted MR images, acquiring diffusion weighted MR images that are highly geometrically accurate, and that can generate diffusion ADC maps or whatever outputs that we want in a robust and repeatable way. I think that would be a key. That would be my other key one, I think.
Thank you. Dr. Haas, how about from your perspective, what are the, one or two things that you would want improved or for an imaging company to consider? Dr. Haas, you might be on mute.
Sorry about that. So my colleagues have hit on a lot of the high points. One of the things that I like and find helpful and would be advantageous is the deformability of images. So we see patients that come from outside that have MRs or CTs elsewhere, PET CTs elsewhere, and the ability to deform the images. And we have the software now where it goes on your simulator field. So a diagnostic head and neck scan or a diagnostic spine scan may show a tumor, and you put the patient on your simulator and the position slightly off. And getting back to the ability to be so precise, if we can completely deform, and the software is there but is slowly getting better, that the diagnostic image is in the same exact plane in all 6 modalities of movement, that we can really focus the beam. Again, I like the comment about integrating functional imaging and treatment, so making sure that can be integrated into the workflow of our planning. But pretty much everything else I agree with what the other physicians have said.
Thank you. So the last question is something that I think everyone on the webinar mentioned early on, and it's the topic of artificial intelligence. So Dr. Chilukuri, I'm going to start with you. From your perspective, if you think of the future of radiation oncology, maybe over the same time period, the next 4 to 5 years, where do you see the role of AI in radiation oncology?
I think there is a huge scope for AI in radiation oncology because there is a lot of imaging data which can easily be automated. I mean, it will not be extremely challenging to do it. I think it can be done very well. I foresee that we would have systems which would generate the target delineation and the OIR delineation very well through artificial simple machine learning tools can do the auto contouring, which has already been done. I'm sure it will be done much more efficiently, much better way. I can see most of the workflows getting automated, the adaptive workflow getting automated, the imaging and image verification getting automated. Of course, I think a physicist is on the panel. I think treatment planning and the quality assurance bit, the patient-specific quality assurance, easily can be automated. There are already multiple ways to achieve that. There are already algorithms which are available, which are being used clinically as well. The quick planners which can generate very rapid plans. So I think several steps in radiation oncology workflow on a day-to-day basis can be automated. But what I hope is the use of AI is to bring in a lot of genomic data, a lot of data which can ensure and enable extremely precise radiation, not in terms of physical precision, but in terms of biological precision, by use of a lot of genomics, use of SNPs, and you can use multiple ways to automate. I think AI is here to stay, and a lot of our workflow are going to get much easier in the coming few years.
Dr. Haas, what about from your perspective? Where do you see AI going in the next 4 to 5 years, and what are your hopes for AI to address things such as workflow?
Yeah, I mean, it's already here. I mean, at least up until this point, in my opinion, the part of our department that's benefited the most is the physics and dosimetry part. So I remember back in the day, physics to do a forward plan would take them a while. To do an IMRT plan would take hours or days. And now with AI, provided that the physician enters constraints that are reasonable, plans can be generated in a very short time, minutes or hours, as opposed to days. So from a planning perspective, efficiency's already been dramatically enhanced by AI. From a physician perspective, and we touched on this earlier, auto contouring, where I don't have to draw every single slice, and that saves me hours to be more productive doing other things. Automating the workflow throughout the department. We have something here called care paths, where we're even rather than kind of handing a chart to one of our patients, everything's just automatically streamlined. I like the comment of having AI to integrate genomics and patient-centric data on an individual basis for each patient. So AI is here. AI has been here for many years. And I think it's going to make us efficient. One thing I hope, though, but it really, you can't replace the human part of it, right? It all starts with, from a radiation oncologist, what are the constraints that you're putting into the AI in the first place, right? The AI, I don't think, hopefully not ever, but certainly not yet, replaces the physician's judgment. What do you want to give? What dose do you want to give? What do you want to limit normal surrounding structures to? So I think AI will expand, and it should. I think it will make us more efficient, but it's important that the human component stay, in my opinion.
Thank you. Jonathan, how about from your perspective?
Yeah, I agree with everything that's been said so far. Just picking up on what Dr. Haas just said there, I think that is a very important question, because as to take contouring, for example, say at the moment you have clinicians with a huge amount of expertise and skill in contouring images, because that's a key part of their day job. In 5 years' time, if actually the vast majority of the time it's all been done automatically, the clinicians will lose those skills. That's inevitable, because they won't be practicing them. And so then the question becomes, how do we then ensure the quality? Where are the systems and the checks? And so to ensure not only that we're getting good, the initial system gives us good results, but how do we test that? How do we check that as we start losing the humans start losing their abilities because they're no longer doing it. So I think artificial, so AI-driven quality assurance of contours, for example, using independent data and independent algorithm from whatever generated it in the first place is going to be a really important component that will highlight, areas of the contour that look maybe suspect and maybe need to be considered and checked. I think another key role, like we mentioned earlier, is improving the patient experience by, using AI algorithms to generate other different imaging modality data from a single imaging modality visit. So you can have a single MR scan, and using that you get MR images, but then you can also generate a synthetic CT, and that saves the patient having to come for a separate CT. That is already what's happening in our clinical MR-only pathway. But I think we could be doing that, that we could be extending that and expanding that into different clinical situations. And I think the final element that we haven't maybe really touched upon, but is actually closing the loop and is saying, we've got these very rich data about how we've treated patients. We've got, dose distributions and images but what we don't have is the follow-up data about what actually happens. And if we could really find ways of getting data available, the follow-up data, that what were the side effects the patients experienced, what did that look like? And then I think using artificial intelligence algorithms can then really data mine those things to really improve and hone what tolerances should we be working towards, what does it look like? And we can actually start doing that with all of our patients and not just patients within a trial setting. I think that could be another key indication and use of AI in the future. But it depends critically on getting good quality data, getting that good quality follow-up data, which I think is a significant logistical and technical challenge.
Thank you. Dr. Bai, from your perspective, what do you see the role of AI or the trends in AI in your region?
Many steps of complex workflow of radiotherapy could be simplified through AI systems, such as segmentation, planning, and outcome prediction. First, manual delineation of organs at risk and target volumes are time-consuming and operator-dependent. And currently available Atlas-based automatic segmentation softwares still require manual correction before clinical use. The development of AI implementation could automatically improve software's performance based on previous collected data. Second, nowadays, radiotherapy treatment plans are still designed by humans. Planners operate treatment planning systems to create satisfactory plans by setting and adjusting parameters based on human experience. This is tedious and time-consuming. Meanwhile, the final plan quality is affected by many factors, such as experience of the planner and available time. AI-based auto-planning could determine parameters to achieve high-quality plans to improve efficiency. Third, AI technology can integrate diverse multimodal information, such as clinical imaging and molecular data in quantitative manner to provide specific clinical predictions that accurately and robustly estimate patient outcomes as a function of the possible decisions, which help oncologists develop a treatment plan that is more suitable for the patient. Okay.
Thank you. I'm going to move to a couple of the Q&A questions just because I know we're getting close to the top of the hour. So the first question is, how do you see the role of synthetic CT images generated from MR images in radiotherapy treatment planning, especially for head and neck, brain, upper abdomen, and other areas? So I'll open it up to the group. Is there someone that'd like to address this question?
I'm happy to do that. So we've introduced that clinically, an MR-only planning technique for our prostate cancer patients, and we're looking to expand and develop that. I think it provides, as we've discussed, as some of the other contributors have mentioned, that image registration between different images can be a real challenge, and often, often because the traditional bedrock of treatment planning is CT based. Often what that means is that you have this wonderful MR image that gives you wonderful soft tissue contrast, but the bladder filling's a bit different, the rectal filling's a bit different, the registration's not perfect, and so you sort of start compromising your MR contouring to better fit with the CT anatomy, because that's what's then the patient's going to go on to be planned. An MR only planning solution just gets rid of that and says, actually, we don't want the CT, what we want is the MR. And then we can then get accurate dose calculations using a synthetic CT based on the MR. So I really think that is, and as well, it saves the patient additional imaging appointments, and improves the kind of efficiency of the workflow. So I really think that basically situations where the CT is not adding value from a contouring perspective, so where it's only been used as a dose calculation and image, I think MR only is certainly the way forward. So certainly, I think we could see that. We found that in prostate. We're exploring other pelvic sites at the moment. There are solutions out there for head and neck and brain, and so I think both of those have good potential as well. And I expect those to be growth areas in the future.
We've got time for one more question, and as I'm going through all the questions, I think the one that I want to ask is around the patients. That's ultimately the reason why all of us are here, is to care for patients that are going through a diagnosis of cancer. So from your perspectives, what is the one or maybe two things that we can do to really improve the overall patient experience? So Dr. Chilukuri, I'll start with you.
I think many aspects can be done. One, in terms of service, I would probably divide this into service, education, and research. Services, how could we improve the patient outcomes by devising better imaging modalities, better treatment delivery machines, better guidance systems, better workflows, better patient management systems. So these are part of service, which imaging company like GE can participate. The other aspect is, I think, education, research, which is also an important key element. And educating the radiologists, radiation oncologists, the technicians, the physicists in using a lot of these technologies to optimal use is also a key element. And research, I think there is a huge scope for genomics. There is a huge scope for integrating genomics with radiation to ensure personalized treatment approaches. And I think, again, there is a lot of imaging is not just pictures, but there is a lot of data behind it. So I think use of that data, leveraging that data on a day-to-day basis, and probably a huge company like yours also could help physicians collaborate with each other, share data with each other through the principles of federated learning, and then use that data to generate the demographic, predictive, and both prescriptive analytics, and to make sure that the final outcomes, for patient outcomes, get better.
Thank you. And Dr. Haas, from your perspective, what do you think are the one or two things that we can focus on to improve the overall patient experience?
Yeah, there's three things that I look at when I see or consider as a clinician with a patient. It's the efficacy is number one. How efficacious is your treatment? That everyone that comes in the door you want to cure if you can. Number two, minimizing side effects. So if advanced imaging enables us to kind of tighten our margins, be more precise, that's where a great company like GE can help. And three, convenience. If I can get a patient out the door, in 5 days as opposed to 6 weeks, that's a benefit. With newer technologies like Flash, if you can get them, we just completed a protocol for single fraction breast, 1 day as opposed to 30 days, that's a benefit. So trying to hit that trifecta of efficacy, minimizing side effects, and efficiency, and that's where technology and companies like yours can help.
Thank you, Dr. Haas. I want to thank all of you for your time and attention this morning, for sharing all of your expertise, and truly making this a global perspective on the trends in radiation oncology. So with that, Anne, I will turn it over to you.
Great. Thank you very much. Thank you to everybody who joined today for participating, and for our wonderful moderator, Andy DeLeo, and all of our speakers, Dr. Senbai, Dr. Jonathan Haas, Dr. Jonathan Wyatt, Dr. Chilukuri. Very delighted to have you on the call, and we will make this webinar available to you through a link that we will send thereafter, and we will also have it available on the link that you accessed in the first place. Thank you very much for joining today, and we hope you have a great afternoon or evening, and we will be happy to have you in our future oncology webinars. Thanks again. Bye.